Just waiting. So we're live. Hello, everyone. Thank you so much for coming. My name is Alex Gordon. I'm the Neurology Coordinator for Mind the Bleep. Normally joined by the other Neurology Coordinator, Terry, who can't make it tonight. But this is a sort of one-off session around sort of applying to neurology in the UK, which is going to be run by Jacob, who I will let introduce himself, and I will drift into the background and turn my camera off.
Great, thanks very much, Alex. Hi, everyone. Let me share my screen. Okay, evening. So, my name's Jacob Day. I'm a neurology registrar based in Plymouth in the southwest of England. And I've just been asked to talk about applying to neurology, which I've interpreted as a kind of quite a broad sort of relaxed talk about neurology specialty, what it's like day to day, with a bit about applying. And I've also been asked to talk about sort of clinical academic side of training as well. So I'm going to talk about my personal experience of neurology training so far. I haven't finished it yet, which will hopefully give you a flavour for what the realities of being a neurology registrar are. I'm going to touch on what's changing in neurology. And again, we'll talk about this in a bit more detail, but I am on an old training scheme because a new one has just come in as of 2 months ago. So anyone who is going into neurology training from now on is going to be on that new scheme. So I'll try and talk a bit about that because that's obviously going to be relevant to people here. And I'm assuming that most of the people logged in here are going to be predominantly junior doctors in the UK who are interested in applying for neurology. I will talk about the application process a bit. A lot of it's online. I won't go through all the details, but I'll try and give you the headlines and the sort of dates and things that I think you need to be aware of and just to have in mind at this stage. And like I said, I'm going to talk about clinical academic training. I've done two posts of clinical academic training during my training. And of course, this is relevant to all medical specialties and not just neurology. So a few disclaimers just to keep in mind as we're going on. This is just my personal experience of neurology. Okay, if you spoke to a different registrar, even in the same hospital, but certainly a different registrar in a different hospital who maybe started a couple of years before me or a couple of years after me, they're likely to have quite a different experience. So just bear that in mind. And as I mentioned, I'm on the old curriculum, so some of the things that I'm going to talk about or that are relevant to me may be a little bit different going forward. And I've only ever worked in the southwest England in the UK, so I've been quite geographically restricted in my experience. So again, just bear that in mind when you're sort of drawing parallels to other parts of the UK. And again, I'm going to talk for maybe 25 minutes or so, but hopefully leave lots of time for questions because I imagine that some people might have questions that are specific to their personal situation or just about something that I haven't covered. So please feel free to ask any questions at the end. So, my experience of neurology. So a little bit of background just to try and orientate you about me. I'll try not to go on about it too much, but so I was born down here in Devon. I went to Cambridge for 3 years, which is somewhere around here. Then I went to Oxford for 3 years, and that was my medical school training. And then I came back to Devon. So I've done, certainly nothing above Cambridge, so mostly South England, and mostly it's been Devon-based. So I did my foundation years and my core training in Exeter, which is about here, the Royal Devon and Exeter Hospital. And I've been doing my specialty training in Derriford Hospital, which is Plymouth, which is just 40 miles down the road, around about here. I did get out for a bit and went to New Zealand between my F2 and CT1 years, which was really great, and I could talk about that for a long time, but that's not really the focus of this webinar. So that's geographically where I've worked. What have I done in terms of neurology? So I did do a couple of posts in neurology before my specialty training. So I managed to kind of ask for and was provided with a neurology attachment in my F2 year. So I did 4 months equivalent of neurology in F2. I then did essentially the same job again in CT1, so it was the same hospital, the same ward, which actually meant I'd done 8 months of neurology before specialty training, which I think is a bit unusual, certainly not expected for people applying for neurology. And of course, I did it in the same hospital, in the same ward, so you could argue that probably the sort of learning experience was not much more than doing it just once. So I'm certainly not saying you have to do lots of neurology before specialty, but just so you know where I'm coming from. I did also do a geriatrics placement during my core training, which had quite a focus on Parkinson's, because the hospital I was working in, the Parkinson's service was run by the geriatricians. So that actually gave me a pretty good handle on sort of inpatient Parkinson's management. And also I got to a clinic most weeks, which was sort of quite unusual and really valuable in my core training stage. So that was something neurology related as well that I did pre-specialty training. But of course, most of what you want to hear about is what specialty training itself is actually like. So I've been doing neurology specialty training since 2019. So I'm in my 4th year now. So I've done ST3, 4, 5, and now I'm in ST6. I've done them all in the same hospital so far. I've just noted down a few things here. I'm going to just splurge at you about what I think about my day-to-day work, the common things we see, just to try and give you a bit of a flavour on it. But I'll try and structure it a bit just around these sort of 4 areas. So, what's a normal week for a neurology registrar? Well, if you take last week, I was on the ward. We have 8 registrars in Plymouth. So we are on the ward 1 week in 8, which means we are not on the ward 7 out of 8 weeks, which is very different to working as a sort of foundation doctor or core medical trainee. So I was on the ward last week. I was kind of paired up with a consultant. We do kind of Monday to Sunday. The same consultant is on call and the same registrar is on the ward and does the weekends. You get really nice continuity. I was on the post-take ward round every day with the consultant, seeing the common conditions that come into hospital and watching, a senior neurologist post-take them. It was a really great learning experience. Plymouth is it's quite a big hospital. It's got about 1,000 beds and it's got quite a big focus on acute neurology. We also run the stroke service and offer quite a lot of the Parkinson's service and also some of the sort of early onset dementia services as well. And those are all areas that aren't always covered by neurology, but they're pretty much all covered in Plymouth. So we have quite a large neurology service in Plymouth. The kind of things that we were post-taking last week, so there's lots of things like headaches. It's really common, thunderclap headaches in people with conditions like idiopathic intracranial hypertension. We need to think if the pressure's going high, and you need to do a lumbar puncture for that. People presenting with strokes, again, really common, TIAs. We had quite a lot of seizures last week. There were a couple of patients in particular that I'm thinking of. One who there's a kind of a new presentation of seizures, and then a lot of that is working out or trying to work out why someone's developed new seizures in adulthood. Is it just late onset epilepsy, or have they got an unusual infection or something rarer like an autoimmune encephalitis? And all those things are treated in very different ways. So you have to be really quite careful about what might be causing seizures. And the other patient that sticks in my mind from last week was someone with known epilepsy. He'd had stroke sort of 10 years ago and had epilepsy as a result of that stroke, was already on a couple of antiepileptics and had missed some antiepileptics because the pharmacy was closed, so started having seizures, then got a chest infection and ended up being, really quite problematic seizures where he had to give him lots of extra medicines and, really get on top of the infection in order to settle it all down. So that's quite a simple sort of reason for having seizures, just missed medicines and you've got an infection, but there's quite a lot of management issues to consider with that as well. So kind of ward rounds in the morning, post-taking, I did quite a lot of ward referrals in the afternoon, so not patients coming in kind of new to the hospital with neurological conditions, but patients who go to other wards who might then develop some problems. So maybe they develop stroke-like symptoms on the ward, or maybe they have like a seizure despite coming in with a pneumonia to begin with, or sometimes patients with sort of chronic neurological conditions who come in for an unrelated reason. So people with epilepsy who are in with infections, they might need a look at in terms of whether they're on the right medicines. If they're not swallowing properly, how are we going to correct that? Or other conditions, myasthenia gravis is something that we need to make sure people stay stable, because they can get very sick if their medications get disrupted, and they can get very unwell, so we try and preempt that. Same with Parkinson's. So there's a real kind of range of things you can see from ward referrals as well as the post-take as well. In terms of what we actually have kind of in on our ward. Well, our ward in Plymouth, every hospital will do it differently. It's kind of a shared stroke and neurology ward, which means that actually the majority of inpatients on that ward are patients with strokes. So I think we only had about 5 patients with non-stroke problems on the ward last week, but then we had a lot of patients in A&E, in the medical assessment unit, and often on other wards as well, which is not ideal for patients, but that's how it is, unfortunately. So I did that Monday to Friday, kind of 8:30 till 5, and then I was on call at the weekends, a kind of normal sort of long day, 9 a.m. till 10 p.m, and then you do all the on-calls, so on-call neurology and on-call stroke. And that's quite a big commitment, the stroke side of things, because obviously stroke is common and there's this real time pressure with stroke to assess people at the front door as they're coming in on the ambulance, making a quick clinical diagnosis, does it look like a stroke, then giving them a quick scan, so a CT or CT angio, deciding whether it's a stroke due to a bleed that needs blood pressure management and reversal of anticoagulants, or actually is it a stroke due to ischemia, and should we be thrombolizing the patient or taking them for thrombectomy? And Plymouth is a thrombectomy service, which is a exciting service to be part of, and is really great for people with big strokes who can get in and access that service. So that's what I did last week, but that's unusual because that's only 1 week in 8. The rest of the weeks are quite a mismatch really. We try and get to as many clinics as we can. We have a nominal target of trying to get to 100 clinics a year. So that works out as roughly 2.5 a week by the time you take annual leave and study leave into account. We're not making that, unfortunately, in Plymouth at the moment, and I think probably it's quite rare for neurology regs elsewhere to make that as well. But ideally we get to when we're not on the ward or on annual leave or anything, to maybe something like 3 clinics, which could be acute clinics like TIA clinics or admission avoidance clinics, where you get access to same day scans, Doppler tests, blood tests, ECGs, and you can kind of make a sort of one-stop shop where you diagnose the patient, you see them, you assess them, you do the test, you diagnose them, and then you think about whether they need to come into hospital, whether you give them the treatment and send them on their way. So that can be quite satisfying. And then there are other more normal chronic disease management clinics. So you might be seeing new patients who've been referred in by the GP, or you might be seeing people with long-term neurological conditions under regular follow-up, things like epilepsy, Parkinson's, multiple sclerosis, headaches. I think they'd probably be the most common ones. So again, very varied. So yeah, that's a mishmash. That's probably a kind of rough kind of idea of our normal week. We try and get 1 session of admin a week, which again is not something you get as a more junior doctor, but you do need it because you generate quite a lot of admin through letters, through clinics, and seeing patients on call and discharging them. So that would be kind of 1 morning or 1 afternoon. And we also have a sort of academic meeting every Thursday morning where cases get presented, or audits and things. And that's for the whole region, actually, so kind of all for all Devon and Cornwall. Okay, so common conditions. Well, I covered some of this already. Again, neurology has a reputation for dealing with rare conditions, but actually, particularly where I work, we see the common things because they are common, and because as a neurology service, we do see them. So headaches, seizures, either new seizures or as part of people with known epilepsy, strokes and TIAs, really common. And then patients with sort of chronic neurological conditions who come in with complications, so things like Parkinson's or MS, although MS is actually pretty well managed as an outpatient now, usually by a specialist MS service. So those are the kind of things you see. We kind of work as a diagnostic specialty quite a lot as well. So we get a lot of referrals for things like, oh, this person collapsed. Could it have been due to a seizure or maybe a TIA causing weakness, and that's why they fell down and they recovered. And sometimes then you just go and see the patients and you kind of take a history and you examine them and you think about any tests. And sometimes it's just like, oh no, actually, I don't think it really is in keeping with a seizure. So please carry on with your investigations for syncope, etc. Fine. So training, I think as any registrar, not just neurology, there's quite a lot more focus on your training. You're going to become a consultant. You have to be trained properly so that you can be a consultant and manage these patients independently. So that's a really nice part of being a registrar. Neurology, we have this thing called Cowman Days, which I think are across the whole country. I think they're meant to be about 1 a month, but they probably work out as more like sort of 8 to 10 a year. and each hospital is sort of designated a topic within the curriculum to give teaching on. And a lot of them done virtually now since COVID, but they're often really valuable and really great. And obviously one poor person has to stay behind and do the on-calls, but the rest of you get this lovely Thursday off and just get taught things. There's quite a lot of feedback from consultants as well. Working through your portfolio becomes a bit more of a sort of useful exercise rather than box ticking, as it can sometimes be as a more junior doctor. So I say the training opportunities, the specified training opportunities are really good. Sometimes we get a bit kind of lost in terms of having to do ward referrals, stroke on calls and things. That means we don't get to quite enough of the sort of training clinics where we get to kind of sit in and see the subspecialty side. But I might come on to that a little bit later. And I've just noted a little bit about practical procedures. So neurology isn't really a practical specialty. So if that floats your boat, it might be best to think about something else. I mean, we do lumbar punctures. A lot of people do lumbar punctures, other specialties, more junior doctors. And then the only other things that we kind of are on the curriculum or for consideration are injections for headaches, Botox for migraines, and then also something called GONIes, or greater occipital nerve injections, which again are used for migraines or sometimes other headache types. So those are the kind of practical procedures we tend to get involved with. There's no real competencies, like you'd have for OGDs or in the cardiac cath lab. So it's quite different from that respect, which is good for some people, but not for everyone. So it just depends what floats your boat. Okay, so that's a very sort of rushed, sort of random explanation of what I think my specialty training has been like and what it is day to day and the kind of things we see. But again, if you've got any more questions, then please do ask at the end. Having assimilated all of this through the last 3 years or so, I come up with this list of good stuff for being a neurology registrar. It is really clinical. You hear people say this about neurology all the time, and I was never really sure what it meant, to be honest. I mean, everything's clinical, isn't it? But I think I do understand it more. A lot of it is just sitting down and talking to the patient, really going through the details of when did your arm weakness come on? How quickly did it come on? Did it spread? Which part of the arm did it affect? Did it involve the leg? Did it involve the face? Was there numbness? Was it just weakness? Was there neck pain? All of that with a history, really detailed, which is going to tell you 9 times out of 10 what the problem is and where the problem is. And then you go on and do your examination, which again, you do a lot of neurological examinations, which in general other people don't do just because it takes quite a long time and it's maybe not so relevant to their specialty. So you become very expert at doing the neurological examination and interpreting it in the context of the history that you take, and then coming up with a decision. And often you can make a diagnosis just based on that without really any scans or anything. A seizure is just a clinical diagnosis just based on the history of what happened according to the patient and the witness, and a bit of an examination to see if there's tongue bites or anything that looks like it might be causing an ongoing deficit that's driving the seizure. So you don't really need any tests at all to diagnose a seizure, which is really nice. Sometimes it's a bit frustrating because you think, well, all I'm going to do is come down and do a history and exam, so why can't the person who's referring do that as well? But obviously, as a neurologist, you see this certain conditions a lot more than them, so it is easier, and then you can also instigate the outpatient follow-up, etc., if it needs to be done. The other thing is that you do just see really interesting conditions, and I think this is the key thing. If you're interested in neurological conditions, then you're going to enjoy neurology. There's a real range, and they are really interesting. And also, we've got new treatments now. Gone are the days where neurologists would just diagnose things and then discharge back to the GP. There are obviously some conditions we can't cure, but in general, there are lots of treatments. Thrombolysis, thrombectomy now for stroke is a real game changer. There's absolutely loads of MS disease-modifying treatments that have really changed MS landscape. There's new anti-epileptics coming out. There's new migraine treatments coming out. There's lots of Parkinson's medications as well, which are not really prescribed in any other condition. So there is lots of management to do as well, and they're really interesting conditions. You often need to work with lots of different specialties, particularly the other neuroscience specialties. I mean, like neurosurgery, kind of neuroradiology, neuropsychology. So you form a bit of a sort of neuroscience network, which is really nice as well. Teaching I mentioned about, and then it is one of those specialties that's quite well set up for opportunities in research or teaching as well. So kind of going out of program for that is kind of, very accepted and probably more easily done than in some other specialties at the moment. I'll put no nights, but I'll put it in brackets because that's probably going to change, and we'll come on to that in a bit. Of course, there's some less good stuff, and I wouldn't be giving you a balanced talk if I didn't highlight some of this. And I would be lying if I said that every day I went in and had a great day, because that's not true. And some things are very frustrating. But before I get bogged down in the less good stuff, the headline is that neurology is a really great specialty and it's really interesting, and overall it's good. But obviously, you need to bear in mind some other things that might put you off. So there is a lot to cover. I mean, probably every specialty says this, but I think it is definitely the case with neurology. And there's lots of subspecialties. You know, I felt like I've made the decision to do neurology. It's like, great, I've decided I'm going to be a neurologist. I've trained to be a neurologist. And a few months in, you start getting asked, well, what part of neurology do you want to do? What subspecialty do you want to do? Epilepsy, movement disorders, MS? It's like, well, wait a minute, I've only just decided what specialty, let alone what subspecialty. And then you realize that some consultants are actually don't really get involved with some of the areas of neurology. So in Plymouth, for example, the MS service is almost an entirely separate service that's kind of run out of a different set of offices with different specialist nurse, and doesn't really come under general neurology very much at all, which is not something I'd really appreciated before I started neurology training. And the same goes for other subspecialties as well. Services often vary. So again, this is going to vary according to where you want to work. You know, some places might have very good sort of genetic neuropathy services or hereditary ataxias, but a lot of places won't have any of those. Rare conditions. I'll put this in the less good stuff. Some people might like rare conditions. I find it quite challenging because it's hard to feel like you're being trained in a condition that you never see, and yet as a neurology trainee or a neurologist, you're kind of expected to know about them. So things like autoimmune encephalitis, which gets talked about a lot because it's kind of a treatable cause of seizures and sort of personality change, of treatable movement disorder sometimes, but it's pretty rare. I've probably only seen sort of 2 or 3 ever. And if someone has it diagnosed and suddenly you're kind of thrown and said, well, this is your bag, it's an autoimmune encephalitis, we need to know what to do with their steroids, etc., etc. You're like, well, actually, I'm not sure because I've not seen it before. So that can be quite hard. But I think that's when you really have to get stuck into the teaching side of things, and you realise that kind of it's really valuable being taught by neurologists and structured teaching days who manage these conditions, and then try and take that into the rare occasions when you do see it. Neurology definitely suffers from this problem, I think, and I think it comes with it being a diagnostic specialty, and sometimes things just are difficult to tell apart. And if someone comes in with a bad sort of migraine, sort of light sensitive, they've had a bit of visual aura, and they get weak down the same side as their headache, well, it's probably a migraine, but if they've never had it before, you really can't tell that apart from a stroke that's triggered a sort of migrainous type headache from just a migraine that's causing sort of some motor weakness at the same time. So there's a lot of kind of scanning people who you think have probably just got a migraine and it's going to get better by itself, but you can't rule out a stroke. So you end up doing a lot of scans that are kind of normal, but you're kind of duty bound to do it if you can't be absolutely sure clinically that it's not something like a stroke that's very, much more urgent and needs very different treatment. So that can be frustrating, and a lot of the tests we send, sometimes the lumbar puncture tests or the autoimmune antibodies can sometimes take days, weeks, sometimes even longer to come back, and sometimes you can't really give a patient a definite result for many weeks, and that can be quite frustrating as well. I am not getting to as many clinics I would have hoped as well, and again, I think that probably is mirrored across a lot of the country, but I can't speak for sure for other places. So I think this is tying into me not seeing some of the rarer conditions, and just making me perhaps not as confident in some areas of neurology I thought I would be. But I haven't finished my training yet, so we'll see where I am in a couple of years' time. Fine, so that was kind of all I was going to say about my experience in neurology, with a little bit of summary about the good stuff and the less good stuff, so I hope that was helpful. The rest of the stuff just going to go through a little bit quicker. So this is one slide talking about what's changing in neurology. And this is all a little bit up in the air because it's only just started. So exactly what form this takes remains to be seen. But there's several sort of non-negotiable parts of the curriculum and training that definitely are changing. Excuse me. So this is the new training procedure for neurology. So of course you do your foundation years, you then go into internal medicine, which is a 3-year program, as opposed to core medical training, which is a 2-year program. So everyone doing neurology is going to have to do 3 of these core training years before they get specialty training. unless you do ACCS, in which case you do 4, and that's gone from 3 to 4. So an extra year, basically. And in your final year of that, most hospitals, as far as I'm aware, are having their IMT3 trainees on the MedReg rota, often coupled up with a more senior registrar, but I think not 100% of the cases. So you're going to be doing some general medicine, acute unselected take registrar on-calls as part of IMT, which was not necessarily the case as part of CMT, which is what I did. You then apply for your specialty training. So I did CT1, CT2, ST3, 4, 5, 6, 7. That will be all of my training. Now it's going to be IMT 1, 2, 3, and then ST 4, 5, 6, 7, 8. So some specialties are dropping their specialty down to 4 because IMT has gone up to 3, so it's still 7 years in total. But neurology is keeping 5 years and 3, so it's actually going to be 1 extra year in total from when you start after foundation years until you complete neurology training. So that's one difference. The other big difference is that everyone in neurology is going to train. So they're going to CCT, which is completion of certificate of training, basically what you get your consultant accreditation in. So they're going to get CCT in neurology and general internal medicine, which basically is general medicine, means you can do the acute unselected take. And they're also automatically going to get subspecialty training in stroke. So actually, people going into neurology now are going to get neurology and GIM and stroke accreditation. At the moment, we just get neurology. So I'm just going to get a neurology CCT. If I wanted to get stroke, then I would have to apply for a standalone stroke fellowship year as an extra year. So that's quite different, and is obviously going to have implications for the type of consultant who's trained and what a consultant can offer to a hospital in the future. Although exactly how that's going to pan out is unclear, because I was talking to Alex earlier, just before the webinar started. There's a shortage of neurologists. There's long waiting lists. We need neurologists to do their normal sort of neurology outpatient clinics. If all the neurologists who are being trained coming up are going to be put on AMU and doing acute take, that means they can't be doing the outpatient clinic. So we still need to fill those up. So whether those consultants are going to be doing the acute take or whether they're just going to be carrying on sort of more like a neurology consultant is at the moment is uncertain. So the headlines: 1 extra year in total of training. You do general internal medicine and stroke in addition to neurology. And how it's going to work out during your specialty training is that you're going to do 5 years. You have to do at least 6 months of stroke. And then 3 months of that will count as general medicine, which means you've got 9 more months to make up, because everyone has to do 12 months of general medicine during their specialty training as part of this new curriculum. So it's going to be 6 months stroke and 9 months of general medicine, and at least 2 weeks of general medicine on calls for the other years when you're not doing stroke or general medicine. So hopefully that makes sense. I won't dwell on that too much longer, but the take-home message is that it's 1 extra year, and it's going to include more general medicine, some med-regging on call, which we don't do at the moment, and stroke medicine automatically as well. Okay, right, briefly, the application process. So timelines is an autumn application. It's done online through the system called Oriel. There's a load of sections which you score points on, which are the same for whatever specialty you apply for. So you can have a look on that online. You can start targeting your kind of what you do with QI projects and that kind of thing to try and maximize your points. Okay, that is the same for every specialty. It's autumn application. So if you're applying this year, you need to do it fairly soon. I don't know the exact dates, but it will be October, November time. You will then get shortlisted simply based on your score. Okay, and the top however many people who score on this paper form or online form will then get invited to interview, which is generally held in March. It's about a 45-minute interview. There's 4 questions and 1 presentation. It's quite broad again, okay? The presentation will be something neurology focused, but as far as I'm aware, and certainly when I did it and what I've heard about people who did it last year, the questions are very broad. It's just things like, talk me through your portfolio, so tell me about your commitment to specialty. There'll be something about your suitability of being an acute medical registrar, so probably some sort of acute scenario, and there'll probably be something about sort of disseminating findings or doing a quality improvement projects audit, something like that, governance. So quite broad. So there probably won't actually be that many hard neurology questions as part of that. But that's March. And again, that's the same for every specialty interview. But there'll be some slight variations according to what specialty you're applying for. If you want more information, just go on this website. It's quite good. It's got, you know, all the sort of time frames and the structures. Okay, so I won't go into any more details about that, but it's online application in autumn and then an interview in March. Fairly general, but you can start targeting things in terms of if you want to boost up your points from now. Okay. Just to give you a little bit of an idea, so this was the neurology applications from 2020, which is the most recent one that they've published online. This is just all the different deaneries down here. NTNs is national training number, so this is the numbers that they offer, and this is how many were filled. So basically the take-home message is that all 50 neurology numbers that were offered were filled. Okay, so there were obviously more applicants than there were spaces in 2020. And there's also quite a lot of variation around the country. So Peninsula, where I work, we have 6 numbers, which is a lot, whereas Bristol, the Severn region, just up the road, had none whatsoever. So you need to give a little bit of an idea on the numbers, particularly if you're someone who wants to work in a particular place. Okay, so last bit, I'm just going to talk about academic training. So remember, this isn't specific to neurology. This is clinical academic training, which can be paired with any specialty. Okay. This is the general structure. So medical school, obviously some people do an intercalated research degree as part of that. Some people do an MD or a PhD during their medical degree. That's pretty unusual, and I won't talk about that anymore. But most people, you know, go to medical school, qualify, maybe have an intercalated degree as part of that, join the foundation program, and at that stage, there is an option of doing this thing called an academic foundation program, which I'll go on to talk about a bit more in the next slide. Then after your foundation years, you go into your IMT or ST numbers, which generally go from 1 all the way up to 8. So this is the kind of straightforward clinical training levels, but you can do alongside your early ST training level something called an academic clinical fellowship. And then in your later ST levels, generally you can do something called a clinical lectureship or an academic clinical lectureship. The difference between these is basically a PhD. So an academic clinical fellowship is something you do before a PhD to try and give you the best opportunity for getting funding and doing a successful PhD. And a clinical lectureship is something you do after a PhD, where you try and build on the research skills and sort of area that you've worked on during your PhD typically. And there's a whole variety of sort of things you can do in clinical academic medicine once you're a consultant. So you can be a sort of someone who's employed by the university directly, and then does just some clinical work. So they would typically do, mostly academic, kind of 80%, something like that, and maybe 10% clinical. Or you do get some consultants who are still employed by the NHS, but they have some sort of research time worked into their job plan. So that's the kind of variation you can get in terms of being a consultant and doing academic medicine. So a little bit more on that. So back in the day, people used to have to do academic medicine and PhDs just kind of in their own time, or certainly had to prepare sort of PhD proposals and grant writing and that kind of stuff and work on projects in their own time. Now we've got these structured schemes, which makes it a lot easier and a lot more sort of realistic. And certainly I don't think I would have got anywhere if I'd had to do it all in my own time. I just think it would have been really, really tough. But you can still do that. So you don't have to go through one of these structured schemes, but certainly if you can get it, it makes it easier. So what are they? So the academic foundation program. So this is generally something you do in your F2. One of your F2 blocks will be academic. It doesn't have to be research. It can be education, leadership and management. I think quality improvement as well. So one of those blocks, so a third of that year is something non-clinical, but in these areas, but you still complete your F2 in 1 year. Okay. An academic clinical fellowship is similar, but it's 25%, so it's a little bit less. It's generally a 3-year program. So I did this. I did an academic foundation program, and I've also just finished an academic clinical fellowship. So I did this for my ST3, 4, and 5. So I had 25% of my time was academic. So I generally took kind of 1 week in 4 where I worked on research work, and then the other 3 weeks I was doing my neurology specialty training. And as long as I kept up with my portfolio, even though I was only doing 75% of clinical work that my colleagues were doing, actually I still finished ST3, 4 and 5 in 1 year. So I did the whole thing in 3 years, and now I'm ST6. The advantages of these are that you get dedicated time. That is the biggest advantage. Your pay is the same, okay? Maybe a little bit less if you're not doing on calls during that, but generally your pay is the same. You get extra funding to go on courses. You get access to the academic environment. You get supervisors, in your institution, which is obviously essential. And they're really flexible as well. And finally, not something I've done yet, but I might do in the future, the academic clinical lectureship is after your PhD. It's 50% academic, so it's kind of a postdoc position, and then you do progress at half the rate. So if it's a 4 year, it can be a maximum of 4 years, and that will get you through 2 special years. So if you start it at the end of ST5, you do ST6 and 7, but that'll take you 4 years. Okay. An academic clinical fellowship is all about preparing the opportunity to apply for and to do a PhD. An academic clinical lectureship is about taking your PhD work forward and trying to get to one of those more senior positions. An academic foundation program is really just kind of the initial introduction to academia, and to try and give you a little bit of springboard up to these other positions. And there are different schemes across the different countries in the UK. What I've spoken about is essentially the scheme for England, and that's all funded by the NIHR, which is like the research arm of the NHS. And there are similar but slightly comparable but slightly different schemes in Wales, Scotland, and Northern Ireland. But I think you should remember that there's a lot of money, there's a lot of focus on trying to get doctors to become researchers, because doctors kind of know the right sort of health research questions that need to be answered, and they're kind of quite good at giving that research leadership. So there's a lot of opportunities that can be taken to try and encourage people to do that. So last thing, some good things about academic training. Well, the some of it is that it is really good. I would argue. You get protected time. It's really flexible. So actually, there were times when I needed sort of 3 weeks, in a row to get some work done. And as long as I gave my rota coordinator enough time, this is during my academic clinical fellowship, that could just happen. You progress at the same rate generally for the foundation program and the ACF, so you don't have to worry about taking more time. You get the extra funding. Yes, I think you get £1,000 a year as part of an ACF. You're also still eligible for your normal study budget and your normal study leave. And as I said before, you access that academic community. There's also no obligation. So if you do an academic foundation program or an ACF, and then you think, actually, research isn't for me, education isn't for me, you just go back to being a sort of straightforward clinical trainee, and you're not lost out at all. So it's a kind of win-win situation, I think. That said, there are some things that people find tricky, and some things that make them harder that are important to bear in mind. You are essentially trying to do sort of 2 quite different jobs. I remember when I went into my academic foundation program, I spent all of F1 just desperately trying to get the hang of clinical medicine, and suddenly you go back to something that's completely new again. Trying to write up a research paper or do some stats, and suddenly there's all these sort of biochemists and non-clinical people who are miles better than you at doing it, and you're trying to catch up again. So that can be quite challenging. It can sometimes be challenging to fit your clinical work into less time as well, but generally people manage it. I was always a bit worried about doing less clinical work and sort of being less sort of clinically proficient, and I think that is something you need to bear in mind. But again, if you're sort of conscious of that, and you make sure you get the most out of your clinical work when you are there, then it can make up for it. I put flexible in less good things as well. I said it was a good thing, but sometimes it can be a bad thing, because sometimes you have to work at weekends and evenings, not so clock on and clock off that your shift work is clinically. So just bear that in mind as well. There can also be some sort of geographical and institutional limitations, and by that I mean, if you want to do research in, I don't know, inherited neuropathies, you probably have to go to Queen Square and work with that specific professor, because no one else is doing that work. And if you're not flexible because you've got family or a house or whatever somewhere else, then actually that can be quite challenging. So you sometimes have to make the sort of location of where you are work for you, or at least think about what's most important to you. Is it working in that particular sort of research academic area, and therefore you need to move to the best place, or is it staying where you live and making the sort of academic environment around you work the best for you given where you are? Okay, I have ended up speaking for quite a lot longer than I was expecting. Sorry about that, but that's pretty much all I had to say. Other than if you are interested in academic training, just talk to people, okay? Academic trainees and leads are just really happy to be spoken to. Email them, do a Zoom call, whatever, and then You can find out what it's like in your area, and often the academic training leads can actually make positions. If you think, oh, in 2 years I'll be quite keen to apply for an ACF, they can sometimes have some wiggle room to create a post, even if one wasn't going to exist anyway. So talk to people if you're interested in academic training. And that is everything I had to say. So thank you very much. If there's any questions, I'll be very happy to take them.
Cool. Thanks so much, Jacob. That's yeah, it's good going over the sort of had a wry smile with some of the academic training stuff as well. Being an AFP myself currently, it definitely hits home the trying to feel that you're catching up with people that are very used to doing it themselves. Trying to write research proposals while you're only 40% of your week is dedicated to that is quite a challenge. So
It's all part of the challenge, but it's easier than having to do it without any of that time, as people
yeah.
used to 10, 20 years ago.
Okay. Has anyone got any questions at all? We can take anything. If you got any, like I said, academic stuff or neurology related content, or just general training in the UK. No, it doesn't look like anyone's going to have got anything. So we'll give it 30 more seconds, then we will just leave it there.
Okay.
All right. Okay, so no one's posted anything. So thanks so much for coming, everyone. What we'll do is we'll just leave it there. If you do have any questions, feel free to email neurology@mindthebleep.com and I can get back to you, or just pass the message on to Jacob. Please fill out the feedback. It's really helpful for our development of future sessions, and check out the Mind the Bleep website as well for sort of our previous neurology content as well. And yeah, hopefully see you soon. We are planning a new series of webinars, but until then,